going to teach you the different kinds of the shock, as I have seen in the group that most of the students are getting problem in solving that type of questions. So I thought that this session would be on that. As you all know that there are five different kinds of shocks, and in these five different types of shock, you need to understand that what is going on with pathophysiology that occur from underlying insult and ultimately leads to shock. Now, in today's lecture, we're gonna be covering that how all the cardiogenic parameters like cardiac output, heart rate, pulmonary capillary wedge pressure, systemic venous resistance, and the oxygen saturation changes in different types of shock. Now, basically on USMLE, how they gonna test you that they will give you a scenario from which you first have to locate that which particular type of shock is it, like either cardiogenic and hypovolemic. And then they will ask you some challenging questions like give you the parameter and ask you the up and down arrows for all that cardiac output, heart rate, systemic venous resistance, and pulmonary capillary wedge pressure. And you have to pick the right answer. So first we go through the all type of shocks, their causes and underlying pathophysiology, and then a chart which clears all your concept. So first we should ask yourself that what's the main problem and what's going on in order to determine that which type of shock we are dealing with. Then talk about the three different things, and the option one is heart which doesn't work, like in cardiogenic shock. The second option is the change in fluid status, and the third one is the low fluid level. Now you know that if heart doesn't work, we are talking about cardiogenic shock. Now, if there is the change in fluid status, we are talking about distributive shock. Please don't confuse the distributive shock with hypovolemic shock, where there is the low level of fluids due to the blood loss. However, distribution of the fluid status, and there is a huge difference between these two. Now, in distributive shock, we can classify it into the further three type and its underlying problem, which help us to recognize that which specific type of shock is this. Now, if there is an abnormal reaction to response to the reaction, we are dealing with the septic shock. Like if there is any kind of inflammation and reaction to that inflammation, we are dealing with septic shock. If we lost sympathetic tone, we are dealing with neurogenic shock. Now, further, I will explain that how you gonna lose sympathetic tone in either kind of the spinal cord and brainstem injury. And if we are dealing with anaphylaxis due to the antigen antibody reaction, we are actually dealing with anaphylactic shock. So via this chart, you will get a brief overview of all types of shock. Now we will move toward the particular type of shock. Now, any underlying insult which damages the heart causes the decrease in the cardiac output. Then decreased cardiac output results in decrease in the blood pressure. And of course, decreased blood pressure results in the decrease in the tissue perfusion. Now I will explain that how these parameter changes in the cardiogenic shock. Decrease tissue perfusion and decrease cardiac output and decrease. Wait a minute. I first have to explain the pathophysiology. Like you know that in cardiogenic shock, there is decreased tissue perfusion. Decreased tissue perfusion results in decreased cardiac output and ultimately decreased blood pressure. Now you can think that whenever the body thinks that he isn't getting enough amount of blood, fight and flight system activates and results in the release of catecholamine, which results in the blood vessels vasoconstriction. Now, decreased perfusion. Second one is decreased perfusion to the kidneys. Decreased perfusion to the kidneys activates the renin angiotensin aldosterone system, which also causes vasoconstriction. First is due to catecholamines. Second one is decreased perfusion to the kidneys results in activation of renin angiotensin aldosterone system. Also, renin-angiotensin-aldosterone system causes the retention of sodium and free fluid in order to correct the cardiac output. Actually, these all are our compensatory mechanism. And finally, number third, that pathophysiology occurs in the cardiogenic shock is the shunting of blood to the brain and vital organ. And as why shunting? Because there is already low cardiac output, so the body preferentially wants to supply it to the brain and our vital organs, and blood flow to the non-vital organs decreases. So these all compensatory changes ultimately like vasoconstriction and the shunting and the retention of the sodium and the fluid results in the increase in the venous return. Why? Because of vasoconstriction. Now you think that more and more blood is now coming back to the heart. Now ultimately what heart have to do? Ultimately it results in increased myocardial work, and whenever there is increased myocardial work, there is increase in oxygen demand. But all these compensatory changes are problematic for the heart in case of cardiogenic shock. Why? Anyone of know you the reasons that why these compensatory changes are problematic? Because already the heart has the problem in contractility. It's cardiogenic and heart can't contract properly. So in that scenario, due to compensation, increased venous return, increased workload, and increased oxygen demand due to compensatory changes causes the heart to pump more, and the heart is unable to pump. So the cardiogenic shock worse and ultimately leads to death. That is all the pathophysiology you can say that occurs in the cardiogenic shock and become the reason of death. Now, in this slide, I describe the main pathophysiology is decreased cardiac output, which get more worse with time. The some common causes of cardiogenic shock is myocardial infarction, it's cardiomyopathy, myocarditis, it's drug induced, like you can say drug like cocaine and methamphetamine, it's due to the arrhythmias, and finally is due to the septal defect. Now, as our first shock is the cardiogenic shock, so we will see what changes occurs in the cardiogenic shock. In cardiogenic shock, cardiac output is down, and because heart isn't pumping properly, but heart rate is increased. Anyone of know you reason that why the heart rate is increased in cardiogenic shock?
To
That
compensate
is
for
the
the decreased output. Oh,
Yes, you can say, but whole concept is that, and that little things, if you get wrong, you ultimately gonna be losing the very important marks in your real exam. Actually, in cardiogenic shock, there is the low cardiac output, which results in decrease in the blood pressure. And we also know that whenever there is decreased blood pressure, there is a phenomena called reflex tachycardia. That is a compensatory mechanism, and reflex tachycardia results in the increase in the heart rate. Central venous pressure is either not changed or increases. Now, pulmonary capillary wedge pressure is increased. Why? Because all the blood that can't be pumped is now back off and pull in the left atrium and ultimately into the pulmonary system, which results in increased pulmonary capillary wedge pressure. Although never ever go to cram this, always cardiac output heart rate, only then you will going to correct your answer on the real deal. Now, systemic venous resistance increases as a part of the compensation. Now, anyone of know that how the systemic venous resistance increases? Actually, there is decreased cardiac output, which results in decreased blood pressure. And you know that whenever there is the decreased blood pressure, the fight and flight response get activated, which results in the release of catecholamine. And these catecholamine is actually a sympathetic response, which results in widespread vasoconstriction and leading to increase in systemic venous resistance and oxygen saturation is down. Now, moving towards our next, all of you are clear about cardiogenic shock?
Yes.
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 All right. Now let's move towards the hypovolemic shock. Now, what's going on? Any underlying event that results in the loss of fluid results in the leaking out of pipes, and that results in decrease in the intravascular volume in the body. Now, there are two different causes. You see there, I have mentioned there that either it's the hemorrhagic or either it's non-hemorrhagic. Like the problem due to the blood or the problem non-hemorrhagic is due to the water. Now, the hemorrhagic causes are the trauma like femur fracture. You normally see that in the road traffic accident, and if the person get the femur fracture, most of the time he or she wanna die. Why? Because of very life threatening hemorrhage, which results in the hypovolemic shock. Other things that can cause the hemorrhagic loss is the GI bleed, like some kind of the ulcers or esophageal varices. Anything can cause blood loss and hemorrhagic loss of volume. And the third one is the postpartum pregnancy hemorrhage blood loss. Now, moving towards the left part of slide, that is the non-hemorrhagic, and it's due to the severe diarrhea or vomiting, burns, and salt wasting. All causes results in the decrease in the intravascular volume, and all that ultimately leads to hypovolemic shock. Now, in the vignette, they will mention only the type of such abnormality, like I have mentioned either the femur fracture or either the burn, or either give the patient who have the vomiting or the severe diarrhea for 3 to 5 days, like that. And they are gonna testing you the concept for hypovolemic shock. Now, moving towards the table for hypovolemic shock, and you know that cardiac output decreases simply because there is not enough volume and not enough cardiac output to pump. That is the reason cardiac output is decreases. Heart rate also decreasing, and again, it's the same reason: decreased cardiac output, decreased blood pressure, reflex tachycardia. And central venous pressure is either unchanged or in the down, and the reason is the volume is down. And the pulmonary capillary wedge pressure would also be down because there is the less fluid and they're present that is present in the pulmonary capillaries. Like you can say that there is such an excessive fluid loss that whole body, even your systemic circulation, even in the right side of your heart and ultimately into the pulmonary, all our there is less blood, and this will result in the pulmonary capillary wedge pressure arrow down. uh, And finally is the systemic venous resistance is up. Why? Because the body is trying to compensate again via the mechanism of vasoconstriction for the hypovolemic shock. Because you know that it's again in fight and flight condition. Again, your sympathetic system activates, and again vasoconstriction results in a widespread increase of systemic venous resistance, and oxygen saturation in all cases is down. I will explain in the last, there is only exception in the septic, and otherwise always remember that the arrow of oxygen saturation in all type of the shock is down. Now let's discuss a scenario, and I want you people to answer this question. A 68-year-old man is brought to emergency department. Now, please focus on the highlight words. With a severe chest pain and a shortness of the breath for the past 2 hours, he has the history of hypertension, hyperlipidemia, and coronary artery disease. On arrival, he is diaphoretic and anxious, and ECG shows the ST elevation in V1 to V3 lead. His vitals are the blood pressure is 82 by 54, heart rate is 112, respiratory rate is 22, and the saturation is the 90%. On physical exam, the patient has cold and clammy extremities, jugular venous distension, the heart has S3 gallop with no murmurs, and extremities has no edema. On investigation, you find that the left ventricular ejection fraction was 25 and the systemic venous resistance is elevated. Now, hypovolemia to fluid loss. Option B, decrease left ventricular contractility. Option C, obstruction of right ventricular outflow. Option D is the loss of the vascular tone due to systemic inflammation. And option E is the acute mitral regurgitation. Anyone of you knows the answer? Can you please in mic?
Option B.
Perfect. And the correct answer is the option B, that is the decrease in the left ventricular contractility. As I have clearly highlighted the word the ST elevation, and ST elevation always go if present in the V1 and V3 is the MI in the anterior leads, in the anterior wall of heart. Most probably it's the left ventricle. And the signs of the cardiogenic shock, like you say that's cold, clammy extremities, jugular venous distension, and the systemic venous resistance elevated, and most importantly, ejection fraction is decreased. Uh, and elevated jugular venous distension, pulmonary congestion, low cardiac index, elevated pulmonary capillary wedge pressure, elevated systemic venous resistance because of compensatory vasoconstriction, and these findings strongly support the cardiogenic shock due to severe left ventricular systemic dysfunction as indicated by the reduced ejection fraction and elevated filling pressure. Now, moving towards the next shock, in that the most of the student gets confused. First, discuss that abnormal response due to the infection like septic. Abnormal response to the infection, which means the septic shock. And in septic shock, any foreign antigen get enters your body and causes the release of the acute phase reactants and results in the massive vasodilation and acute phase reaction. Second one is the neurogenic shock, in that there is the loss of sympathetic tone or the neurogenic shock. Like you would say that there is some injury to the brain and spinal cord, which ultimately results in decreased body ability to use its sympathetic tone, and results body cannot vasoconstrict. Why? Because the body has loosened its sympathetic tone. So now when there is no vasoconstriction, what it do? it directly vasodilates. And when anything vasodilate, it causes the changes in distribution of body fluid, and that's why it's included in the type of distributive shock. And our third one is the anaphylactic shock. We actually, in anaphylactic shock, we have IgE mediated type 1 hypersensitivity reaction that causes the change in the histamine and mast cell degranulation, and due to release of histamine and massive degranulation results in the widespread vasodilation. That is the main thing here, is the type 1 hypersensitivity reaction. Like you can say that in all the types of distributive shock, there is either direct vasodilation or unable to vasoconstrict, which also results in the vasodilation. So that vasodilation results in the changes in the distribution of the body fluid, and that's why its name is anaphylactic shock. Now, you know that what the common thing there in all type of distributive shock? It's vasodilation. That is the common. Now, there are the absolute high yield USMLE clues which are present in the vignette, and you will gonna get the answer if that are present there. Like if they given you the bradycardia and the warm shock, if they give you the flushed skin and urticaria and wheezing, go for anaphylactic shock, wheezing, urticaria, flushing due to IgE mediated reaction. I will ask you these points and you have to answer me. And the tachycardia, pounding pulses, and infection history, all are changes that happens in the septic shock. Now, in the septic shock, you know that why cardiac output is up, and I will tell you he and she is ultimately genius if he and she can answer with reason that why cardiac output is up. Like how you can say the whole mechanism, how compensatory, I will explain you.
Increase the sympathetic drive and the heart rate will increase. So the contractility will increase. That's why cardiac output is going to increase.
Because body has to eradicate the infection. So it's in response to the inflammatory reaction, and body is trying to eradicate the infection as soon as possible. So the pulmonary capillary wedge pressure drops in the septic shock due to the same reason, because there is, due to the widespread vasodilation, less blood in the pulmonary system due to increase the cardiac output. Like as the cardiac output is increasing, along with that there is a widespread vasodilation, and vasodilation results in the decreased preload. Less blood is coming into the right atrium and more blood is leaving through the left ventricle, which results in the drop in pulmonary capillary wedge pressure in the case of septic shock. And systemic venous resistance is down in all three type of distributive shock, because the commonality between them is that all the distributive type of shock features vasodilation, which results in decreased systemic venous resistance. And septic shock, that is only exception in case. Next, moving towards the neurogenic shock. In neurogenic shock, the cardiac output and the heart rates both down because of inability to use the sympathetic tone. I have again saying that in neurogenic shock, either there is the brain or the spinal cord damage, which results in the decreased sympathetic tone and decrease activity, or you know that sympathetic tone is ultimately needed to increase the cardiac output and heart rate. Now, when there is no sympathetic tone, ultimately your cardiac output and your heart rates gonna drops. Moreover, systemic venous resistance is also decreases. Why? Because you don't again have sympathetic drive to maintain the vasoconstriction. So vasodilation ultimately results in the decrease in the systemic venous resistance. Again, the reason is vasodilation. Now, the vasodilation results in decrease in preload which results in decreased venous return and ultimately results in the decrease in the pulmonary blood flow and results in pulmonary capillary wedge pressure and oxygen saturation also down just because of vasodilation. And finally, in the anaphylactic shock, it's actually due to the type 1 hypersensitive reaction. The cardiac output is down because of massive vasodilation, which results in decrease in the venous return and decrease in the cardiac output. Now, again, heart rate increases due to the reflex tachycardia, as in the reflex tachycardia as a result of decreased cardiac output and blood pressure. In anaphylactic shock, your central venous pressure, systemic venous resistance, and pulmonary capillary wedge pressure all goes down. Anyone know you the reason that why these three parameters get down?
What is the question?
It's because I am saying in anaphylactic reaction, why the central venous pressure, systemic venous resistance, and pulmonary capillary wedge pressure all goes down.
Because of vasodilation.
Perfect. Vasodilation. It's the vasodilation which results in the decreased systemic venous resistance. So decreased systemic venous resistance results in the decreased venous return, which results in decreased central venous pressure. And finally, less blood flow towards the pulmonary system, which results in the decrease in pulmonary capillary wedge pressure. Oxygen saturation
Galina,
again.
kindly explain septic shock again.
Sorry?
Please explain septic shock again, like how cardiac output increases and the other
Now,
parameter decreases.
uh, what happens in the septic shock? Oh, okay. Now, what happens in the septic shock? There is an antigen. There is a foreign antigen. And all the things that have to compensate or fight for that antigen are ultimately in your blood. So, what the body has to do? Body has to pump more and more blood to so that it can reach that area where the antigen lies, and so that it can like fight against that antigen. So, in response for fighting against that antigen, simply our heart contract more and more cardiac output. So more cardiac output is actually a compensatory response in results of inflammatory reaction so that the more blood flows go where the antigen lies and more blood product get released and more neutrophils, more macrophages, all of them gonna counteract these antigen in foreign body. All right. Now, you also know that in septic shock, we say in the back slide that it's a kind of distributive shock and there is a widespread anaphylactic, there is a widespread vasodilation. And the reason is from because you know that there are a lot of things which are secreted by the neutrophils which results in the widespread vasodilation. Like you can say in infectious state, there are widespread C-reactive protein from the local site of the endothelium. All that results in vasodilation. And whenever there is a vasodilation, there is the pulmonary capillary systemic venous resistance decreases. And when the systemic venous resistance decreases, it means your preload is decreasing. And when your preload is decreasing, mean the less blood is coming to the right atrium, less blood to pulmonary, and less blood to left atrium, which results in decrease in the central venous pressure and pulmonary capillary pressure. Now you get my point?
Yes.
Now, moving towards a scenario, a 63-year-old is brought to the emergency department with fever. Again, focus on the highlighted points. With fever, chills, and confusion for the 12 hours. He has type 2 diabetes mellitus and chronic kidney disease. His wife says that he has a UTI 3 days ago and he was started on oral antibiotics. On arrival, he is confused and lethargic. Vitals are 85 by 40, their respiratory rate is 26, saturation is 93. On exam, the skin is warm and flushed. You know the skin is warm and flushed due to vasodilation. Capillary refill time is less than 2 seconds and the suprapubic tenderness. Always remember suprapubic tenderness is always whenever the bladder is involved uh, in the case of UTIs. The lab shows the white blood cells 18,700, lactate 4.8. Which of the following best explains this patient's hypotension? Anyone of know you knows the answer?
It's option C.
Decrease myocardial contractility, increase systemic vascular resistance, widespread peripheral vasodilation. And yes, you are correct, it's widespread peripheral vasodilation. And the explanation is that it is the classic cause of early septic shock. Infection source, like they mention, is a UTI, which results in the urosepsis. Your vitals are hypotension, decrease in the blood pressure, which results in the reflex tachycardia, and ultimately the fever is due to the infection. The skin is warm and flushed, that results due to vasodilation and is the key sign of the distributive shock. Lactate increase is the sign of tissue hypoperfusion. High white blood cell count suggests that there is some systemic inflammation. Now, you know that this shock topic is also very complicated. And although I have arranged another topic too, that is AV blog in today's session, but I want you people like either I have to go for that or I didn't have to proceed for it because it's too is complicated.
If we don't do it
Either
now,
I
will we
have
do
to
it later,
proceed for
or
the
we
next
will?
AV blog.
If we
You
don't do
can
it now, will we
No,
proceed.
do
no,
it later?
not any problem at my part. I can do it. I am just, yes.
I think we can.
Yes, you can.
All right. I have a question from you people. I have a question from you people. Here I have mentioned its saturation is increased. Anyone of knows the answer that why oxygen saturation is increased?
The blood flow is increased, therefore,
Actually, the
the
reason is that
extraction of oxygen won't happen. That's why the saturation will increase.
Because of the aerobic bacteria.
uh, yes, you
Because the
can say,
Because
infection,
of
yeah.
but the main reason is that
increased blood flow will
yes.
inhibit the complete extraction of that oxygen. So
Because of
that's that.
increased blood flow, there is increased supply of oxygen to the area where infection present.
Uh, yes, supply is increased, but I have mentioned oxygen saturation. And answer is that the oxygen saturation is down, is increased because sepsis affect the mitochondria. So the mitochondria is unable to utilize the oxygen. So that cellular oxygen utilization pathway get down. Oxygen can't be utilized via aerobic pathway, and ultimately your blood saturation increases. So always remember the mnemonic that septic shock is a SAT. That SAT mean only saturation is increased in the septic shock. Rest, if any of the shock apart from septic shock arises, always go for the down arrow. All right. And another exception is the neurogenic shock. In neurogenic shock, the heart rate is down. And again, reason the heart rate is down because in neurogenic shock, sympathetic pathway is inhibited. In all that, there is a compensatory mechanism which results in increased heart rate. However, in neurogenic shock, that sympathetic pathway gonna disrupt, so decrease cardiac output, decrease heart rate, because you know that it's sympathetic system which reacts on your SA node and the blood vessels, certain receptors, and results in the increase in the vasoconstriction, increase heart rate, increase BP, and increase cardiac output. So no sympathetic response ultimately results in decreased cardiac output and decrease in the heart rate. Now moving over the next height, that are I would say that are the AV blocks. Before moving towards the normal ECG in the AV block, let's first master the concept of the normal. In normal, you have the P waves, QRS complex, T waves, and PR interval begin from the start of the P wave to the beginning of the QRS complex. Now, in normal EKG, PR interval is less than 200 millisecond, like which is equal to the 5 little boxes on the EKG. Now, in this case, you will see that there are approximately 4 small boxes. Now, whenever we say that PR interval is increased, we means that it is the more than the 5 small boxes. And always remember that these 5 small boxes gonna make the one large box in the EKG. So your PR interval never ever like be lengthened from the one large box or either 5 small boxes. Now it's all about the normal ECG. Now moving towards the first degree heart block, first going to start with first degree AV block. Now the AV block is the block in conduction system down from SA node to AV node. So the his percussion system never gets activated correctly, and therefore your heart can't beat efficiently. So in the vignette for first AV block, you might be given that the patient is experiencing dizziness, syncope, slow heartbeat. So must be there is the electrical conduction abnormality. So first AV block look like this in the ECG, like you have the constant prolonged PR interval. When I am saying like constant, then I will explain progressively increasing. You have to know the difference in which cases there is a constant, in which cases apart from other like there is increase. In case of first degree heart block, there is the constant, like you say, it's the constant PR interval. It's constant. It's not progressively increases. In all the beats, there is and you see in this ECG that they are covering 3 big boxes, like you say 1, 2, and 3. And I have said that normal ECG, your PR interval would never ever be longer than the 1 longer box or the 5 smaller box. And in that case, it's covering the 3 large box. So ultimately, it's the case of the PR interval. and but the rhythm is normal and PR interval is normal, so we will go for first degree AV block. Now, moving towards the second degree AV block. Now, in second degree, we have two types. One in the Winky block, and their second one is the Mobits, and there are the huge difference. If you only know the pit points and the buzz point, you're gonna be like whatever how much difficult the scenario is. If you know these points, you will gonna be correctly marking the question, the answer on your form. First is the Venki block or the Mobitz type 1. In this, the PR interval is progressively prolonging. In first AV block, it's constant. In that, it's progressively prolonging before a QRS is dropped. Please, please do concentrate on the ECG that I have listed. Like PR interval is progressively increasing, it's progressively increasing, and then ultimately it results in the drop beat. I again emphasize that PR interval is not fixed in type 1 Winky Bog as it's fixed in the first degree and Mobitz type 2. In Winky Bog type 1, it's progressively prolonging with skip beat. That is, like you have 3 to 4 beats until you drop a beat or a QRS. So in the EKG, you clearly see with each beat PR interval keep on increasing until you drop a beat. I have made a mnemonic for it like longer drop. That is a winky back. Okay, longer back. That is a winky back. Like PR interval progressively prolonged until there is the drop beat. Now moving towards the Mobitz type 2. Here also there is the PR interval prolonged, but that is the constant. Like interval is constant and is not progressively increasing as like the Mobitz type 1. Constant prolonged PR interval, then you get a beat drop. Like you would say, there is the constant prolonged PR interval and then a skip beat. Your interval is constant. First, also there is constant first AV block, but no drop beat. Mobitz second degree, Mobitz type 2, also constant increase PR interval along with drop beat. In Mobitz type 1, there is progressively increasing prolonged PR interval along with that you can say that it's the drop beat. So you must know the difference between these two. Next is the third degree AV block, and that is the high yield, I would say. Now, what happens in the third degree AV block? Like your atria and the ventricle contract independently on one another. There is totally loss of connection. They both work, they both squeeze, but such an abnormality that they both work independently and there is no connection between atria and ventricle. So the ECG has no characteristic finding. But one thing is there is the constant PP interval and there is the constant QQ interval. Here you can say that although they are not like after following the P wave, there is not QRS complex, but all the P waves are at equal interval. All right. And moreover, there is, you can say, that constant Q interval. Although there is not a proper PQRS complex, but the distance between P to P and Q to Q is normal. Atria and ventricle contracts independently. They both contract at their same ectopic rate. Like the atria have their another ectopic foci, ventricle have another ectopic foci. So that is the reason that interval between both of them is the constant. Now look in the EKG, P waves all are equal interval. Now look at the Q interval. You will also see that they are in same equal interval. This is a very characteristic for the third degree AV block. One another thing that is characteristic is that even although the atria and ventricle contract independently, it's possible that P wave is buried under the QRS complex. Like in the first strip. In the first strip, you see the second QRS complex. In that second QRS complex, the P wave is buried under the QRS complex. So in the vignette, they will give a patient with syncope, fainting, and then this type of the ECG in the first strip, and you would say that, oh, this ECG, like it's have abnormal QRS, PR interval, all things are abnormal. But whenever you compare like its PP interval and the QQ interval, it's the constant, and then only via this option you will going to answer that it's the third degree heart block. Now you know what's the difference between the first, second, and third? First is constant. Second, type 1 is progressive increasing with drop beat. Second Mobiles type 2 is the constant increased PR interval with drop beat. And third, there is irregular P and QR is complex but with constant P to P and Q to Q interval. That's all for today.